everyone. On behalf of the Egyptian Representative Committee of the Royal College of Obstetricians and Gynecologists, it's my pleasure to welcome you all today in this webinar named Rationalizing Caesarean Section in Egypt and Implementing the Egyptian Healthcare Council Guidelines. My name is Wafa Basta. I'm the Vice Chair of the ERC-RCOG and a member of the National Guideline Development Group. Today, of course, as we know, cesarean section, although it is one of the most important life-saving procedure in obstetric, however, if this operation done in without appropriate indication, it exposes women and babies to unnecessary short-term and long-term risks. In Egypt, we have one of the highest cesarean section rates all over the world, and this makes the implementation of evidence-based national guidelines not only something which is desirable, but it is very essential. And in today's webinar, we are going to introduce those newly developed Egypt Health Council guidelines and how it is going to be applied, how it is developed. We are privileged that we have distinguished national experts who have played major roles in the development of the guidelines, and we will listen to them and kindly put your questions in the chat box, and we will have the questions and the answers at the end. Without any delay, let's begin. It's my real pleasure to invite our first speaker, Professor Yasser Abu Talib. Of course, he doesn't need any introduction. Professor Yasser is the chairman of the ERC-RCOG and professor of obstetrics and gynecology at Shams University and the Military Academy. Professor Yasser, of course, is one of the leading advocates for improving obstetric practice and promoting a high-quality healthcare in Egypt for women. Please, Professor Yasser, the floor is yours.
Okay, good evening, everyone. This is Yasser Abu Talib from Egypt. So it's my pleasure actually to be here with you, participating in such a wonderful, respected webinar discussing a very important issue, which is rising cesarean section and how can we combat it. I have been working in the field of different society and different scientific and social problem in Egypt over the last 40 years. And it's a great pleasure actually to be with my professor who taught me many things, Professor Abdulhamid Atiyah. He was always the lead for the community services and combating problems in Egypt. Not only that, but as well as I was working, and I'm still working in Shams University, one of the biggest university in Egypt. It was a great pleasure actually to join during these last 40 years. One of my best colleagues, it's Dr. Muhammad Murad, who is a fellow of the Royal College, and as well he was the director of Egala Hospital. And every place I go to participate in any activity, I used to find him there just giving his support. No one can deny that the cesarean section rate here in Egypt is sky high, reaching to 70 something, and I can say it might reach in some places to 90. Despite the fact that it's very important to save the lives of the baby and the mother in cases, however, without certain indication, it carries great risk. Nowadays, two risks had been raised and sky high nowadays: placenta accreta, which carries a great risk for maternal mortality and morbidity, which might end by hysterectomy. Not only that, but niche as well, which become as the sun everywhere, every place, just spotting and abnormal bleeding, and why that? Because of niche, which we haven't heard about it long time ago. Today we are going to have a very fruitful discussion discussing how can we decrease the cesarean section rate and how can we manage cases using a special protocol which was invented and created on Egyptian hands. And I think when I say Egyptian hands, it must be the pioneers in this process. Why? Because we have the highest cesarean section rate and overall population all over the world. So it gives me the pleasure actually to join three of the giant persons, Professor Dr. Abdulhamid Atiyah, Professor Dr. Mohammed Murad, and Professor Dr. Ahmed Sekitori, who I think no one can introduce any one of them because everyone know them, and all of them give their hands and put their hands and their knowledge in a special way to create special guideline to reduce the cesarean section rate in Egypt, and I think it will be successful. Over the coming time, we are going to discuss this issue, and I'm dead sure that you will enjoy it very much. Just before giving the mic to my colleague, Dr. Wafa, I would like just to announce a very important thing, which is our international congress, which will be held during 2nd and 3rd December, which will be an intercontinental Nile. No one can deny that it will include loads and loads and loads of national and international speakers. And you know that we are desperate actually to bring you up-to-date information and knowledge. However, we are going to be joined or around this Congress, and nowadays we have lots and lots and lots of scientific and clinical activity, which is considered a unique for the Egyptian Representative Committee of the Royal College, especially hands-on training. In the field of laparoscopy, we use it to offer total laparoscopic hysterectomy, which become 3 days hands-on, and we are preparing one now and one around the Congress. Another hysteroscopy course, which used to be for 2 days, hands-on as well. And the most famous one in the Middle East is the Urogynec course, which is discussing the pelvic floor surgery and urogynecology, which is 3 days courses hands-on. We used to do maybe 50 cases or something like that, hands-on, do and support the candidate attending this course to do this as well. However, basics are very important for us. Basic practical skills to know how to handle the surgical skills is very important. It's a course, and in the field of obstetric, it's robust course. How to do forceps, how to ventouse, how to use CTG, and because of maternal infant mortality is very important and should be prevented, we have a dedicated course which is physiological CTG, not the classic one, which is clinically applied CTG and how can we use it. And preparing people for getting the RCOG, we have third courses related to 2nd and 3rd part preparatory stages for the Royal College. And as well, we have AI course related to obstetric and gynecology. Lots and lots and lots of activity, and we will be very happy to join our team. At the end of this presentation, we will have our phone number if you wanted to participate in our activity. Again, it's our pleasure actually to have such a wonderful, respectable persons, Professor Dr. Abdulhamid Atiyah, Professor Dr. Mohammed Murad, and my dear, 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 dear unique oncologist, gynecological oncology surgery, Ahmed Sekitori, to start this webinar. Please, Professor Dr. Wafa, would you mind to start, please? Thank you very much, and have a nice day. Bye-bye.
Thank you so much, Professor Yasser, for the very inspiring opening remarks. And thanks for all the efforts and the dedication leading the team and the family of the ERC through all those activities. Actually, we stand with pride having the new Egypt Health Council guideline. At least at the end, we have a national guidelines in Egypt. This is because of a very dedicated group chaired by Professor Abdulhamid Atiyah working on that. And we always have questions how those guidelines are developed. Are they new guidelines development or adapted or adopted? Sometimes we have many questions. So our next speaker will provide us with an overview of the Egypt Health Council guidelines and the philosophy behind their development. It's my great pleasure to introduce Professor Mohammed Murad Youssef, ERC-RCOG. He is the director of the National Clinical Guideline Program at the Egyptian Health Council and the consultant obstetrician gynecologist at El Jalaa Teaching Hospital. Professor Murad has been instrumental in leading the national guideline development process through all specialties. It's not only the OBGYN. He is responsible for the development in the Egypt Health Council for all the specialties. Please, Professor Murad, the floor is yours.
Thanks, Dr. Wafa. I'll start by saying I'm proud to say that Egypt is the first country in the EMRO region to establish its own national clinical guidelines program. 22 countries in the EMRO regions, we are the first. And why it's very important to have clinical practice guidelines, there are two main aims. First, translating evidence into practice. In other words, our practice is evidence-based. And the second is standardization. And standardization helps to improve the quality of the provided health services through many ways. One of them, it allows auditing of hospitals, how they are dealing with each case. The management is evidence-based or not. So it's very important to have clinical practice guidelines. And by law now, the Egyptian Health Council is the only authority responsible for developing guidelines in Egypt. And also I want to state that the medical accountability law stated that the reference will be the clinical guidelines produced by the Egyptian Health Council. Next slide, please. All right. If there is a difference between protocols and guidelines, most physicians all over the world tend to use both terms interchangeably. Also, there is a lot of difference between guidelines and protocols. Next slide. Regarding the guidelines, they are mainly about evidence-based recommendations using methodology. There are many methodologies for developing guidelines. We will come to that, but we are using in our program what is called GRADE methodology. The differences between guidelines and protocols mainly are in the flexibility. The flexibility in the guidelines is high. Clinical judgment is necessary. And also the clinical guidelines usually are developed by national or international organizations. The scope, it's usually broad, but it's not a must. Some guidelines are about use of folic acid in pregnancy or use of steroids in malaria. So it's not always that scope of the guideline should be broad. Mainly the guideline development group, what we call GDG, is the one responsible for defining the scope of the guideline they are writing. On the contrary, protocols are mainly developed by hospitals or a department in the hospital. And they are strict, there is no flexibility. Everyone should stick to the protocol, and you are not allowed to break the protocol. except, for example, in some countries, the consultants can break the protocol, but if they broke the protocol and any complication or morbidity or mortality happens, they are not covered by insurance. Next slide, please. As I said, protocols are strict, very low flexibility, developed by hospitals or department of the hospital. And what happens usually is that the ideal process is that every hospital should develop its own protocols that are consistent with the national guidelines. However, this is maybe not applicable in Egypt, as many hospitals in the Ministry of Health lack the human resources to develop its own protocols. So our reference in Egypt will be the national guidelines. Unless the hospital has its own protocols, as I said, which should be consistent with the national clinical practice guidelines. All right, how to develop a guideline? There are three ways of developing guidelines. Either de novo synthesis, which is very complicated and very costly and needs experiences that we still lack in Egypt, I mean methodologists. Just to know, each guideline, de novo synthesis, takes between 18 to 24 months to develop a guideline through de novo synthesis. So it's a complicated process. The second way is adoption. Adopting an international guideline without making any changes in it, which is usually not suitable for our context in Egypt. So again, adoption is not the way that is usually suitable for us. So in our program, we are using the third way, which is adaptation. And adaptation has many ways. Adapti was first introduced for adaptation of guidelines, but recently, the more recent way is GRADE methodology. GRADE methodology is used by around 70 international organizations all over the world. And in our program in Egypt, we are using GRADE methodology. And GRADE methodology allows contextualization of recommendations, which is very important to adapt the recommendations of the international guidelines to our resources in Egypt. And it also allows efficient use of existing guidelines and existing evidence. And by evidence, we mainly are speaking about trials, systematic reviews, meta-analysis. This is the evidence. Next, please. All right. The process of developing a guideline starts by the first step, which is topic prioritization. How to choose the topic for a guideline. And it depends in many factors, whether disease-related factors like the health burden of the disease or the economic burden of the disease, the interest of all stakeholders, whether at the health professional level or the consumer level or the higher authorities level. Practice, if you have a malpractice or variation in practice in a certain area, this is a priority for you to develop a guideline in this area. If there is availability of evidence, we have many international guidelines, so it's like a bank for us to make our own guidelines, because if you can't find an international guideline for a subject and you want to make a guideline, you will have to do it de novo synthesis, and as I said, this is very complicated. Also for topic priorities, next please, the potential impact of the intervention, impact on whether on the health outcome or on the economy or on the health system. Also, the implementation considerations are very important when writing a guideline regarding is this guideline, after producing it, will be easy to implement in Egypt or not. All these factors decide which topics you are going to start by it in the clinical guidelines program. So the first step was the topic priority. The second step is to define your guideline scope. For example, if you are making a guideline about any subject, whether the guideline will cover the diagnosis only or the diagnosis and management, or you will add prophylaxis, you decide the scope as a guideline development group, what we will cover in this guideline and what we will not cover. For example, maybe certain problem only in adults. We are not speaking about children. So you define the scope of your guideline. After defining the scope, usually during defining the scope, we use the PICO question, the PICO population intervention, comparator or control and outcome. So you decide what questions you will answer in this guideline. And each recommendation is an answer for a PICO question. Like the ERC-RCOG guidelines, you will find the PICO questions and below it the recommendation. But it's not a must. Some guidelines don't write the PICO questions in the guideline. Next, please. Next, please. The next step after developing the PICO questions is searching for guidelines. As I said, we are adapting or making adaptation of international guidelines. So we start searching for international guidelines that cover the subject we are developing a guideline for it. The correct step is, after finding international guidelines, to appraise these international guidelines by a checklist well known all over the world called Agree-to tool or Agree-to instrument. It's a 23 questions checklist to give a score for any guideline. For example, when we produce our guidelines in Egypt, anyone in any country can subject these guidelines to the Agree-to and give us a score. And just to inform you that these 23 questions are not about the scientific content of the guideline at all. They are all about the methodology of developing the guideline. If the methodology is correct, you will have a higher score. This is why we are concentrating on the methodology of developing guidelines in Egypt. Next step, updating evidence. For example, if we don't find a guideline for a certain subject, except, for example, a guideline which was produced in 2010, 16 years ago, most probably the evidence may have changed because of newer trials that have been done. So if the guidelines you are adapting from are old, you may have to update your evidence. I mean by updating evidence that you have to search for new systematic reviews, new trials, then writing the recommendations. And this is the main important of any guideline. As I said, a guideline is about evidence-based recommendation. This is when we have to adapt. I said adaptation of guidelines. We cannot adapt the evidence. I mean, we cannot change the grade of the evidence. For example, if many multi-center randomized controlled trials have been performed on a certain area, and they have found that a certain drug is very effective and the grade of evidence is high, I cannot say here in Egypt, no, I'll say that the grade of evidence is low. I cannot change the grade of evidence, except by assessing this evidence in a certain way, and most probably we will agree with the grade of evidence that is in the international guideline. You may downgrade it by 1 grade only because what we call indirectness, because most of these trials have been done on populations that are not related to the population in the Middle East region. And in this, we can downgrade the evidence by 1 grade. But for the strength of the recommendation, we are free to change the strength of the recommendation. For example, if the recommendation is written in the international guidelines that it is a strong recommendation, I can say here, no, it's not a strong recommendation, it's a conditional or weak recommendation. And we change the strength of the recommendation not by will, but through the grade methodology. Because in grade methodology, the strength of the recommendation depends on 8 to 9 factors. One of them is the level of evidence, but there are many factors that determine the strength of recommendation, like the balance between the beneficial and harmful effects, the patient's preference and values, and in many countries, the guideline development group includes a patient representative who gives his opinion about the guideline. So the patient preference is one of the factors that determine the strength of the recommendation. The equity between patients, for example, in MS, the vial is $3 million around now. If we have 5,000 patients in Egypt and the budget of the Ministry of Health can bring only 1,000 vials, who will take and who will not take, this may be biased. So the equity between guidelines should advocate for equity between patients. So if there is a very expensive drug, I can't write it as a strong recommendation here. And this is also applied in each country. Not only we are depending on our resources, there are some countries that have low resource scenario guideline and high resource scenario guideline. And in each guideline development group abroad, there is a health economist in the guideline development group. Here in Egypt, we have the help of the Unified Procurement Authority sometimes if there is expensive drugs. Also, the resources determine the strength of the recommendation. After we define the strength of the recommendation and write the recommendation, a draft of a guideline is produced, external review is performed, and then the final guideline is produced. The next steps is dissemination to let people know that there is a national clinical guideline program in Egypt. And these guidelines are present on the website of the Egyptian Health Council, free. And then monitoring of implementation of these guidelines in the hospitals and evaluation of the impact, and lastly, update of the guideline whenever there is new evidence. Next, please. This is a link for the national clinical guidelines. Thank you for your attendance.
Thank you so much, Professor Murad, for this excellent overview for the guideline development process. It was really very interesting to hear, and I believe many are interested in the process itself. It was very clear. Thank you so much. And we will keep the questions till the end of the webinar. Our next session moves from the guideline framework to the practical clinical strategies. We are honored to welcome Professor Abdelhamid Atiyah, Professor of Obstetrics and Gynecology, Cairo University, and Chairman of the Obstetrics and Gynecology Guideline Committee, the GDG, of the Egypt Health Council. Of course, Professor Abdelhamid has been one of the key architects of the recommendations and the guideline development through the years. Today, he is going to discuss with us a clinical intervention for prevention of the primary cesarean section rate. Dr. Hamid, اتفضل.
Good evening, everybody. First of all, I am very pleased to be present with you today to present something that's very familiar to every one of us. It's about cesarean section. There is no one who is not familiar with cesarean section, how to perform it, what are the indications, and when should it be done and when should it not be done. First of all, before delving into the cesarean section itself, I would like to give you an overview about the medical liability law, the new law about the medical liability. This law is in action now, and every one of us should know it by heart because we are all treated according to this law. I would like to show you some outlines or headings. The first is the consent, the informed consent. From now on, please, everyone, it is very important for you, before doing any procedure, not only surgery, any procedure to your patient, you have to get an informed consent. And this informed consent, you have to describe the procedure, what are the possible complications that may result from this procedure, and have the patient sign this consent. This is very important to keep yourself away from accusations if anything happened. And now we are in an era, every patient who is not satisfied by the service she gets, she goes to the police, she files a lawsuit against the physician, and by virtue of my presence in the Committee of Medical Liability, لجنة المسؤولية الطبية in obstetrics and gynecology, I find a lot of lawsuits that has no real ground to be raised, but this informed consent is a life-saving for every doctor. So please, I am insisting, I am saying it once, twice, and thrice, please don't forget the informed consent before any procedure or any surgical intervention. This law has differentiated between three important things: the complications, which can happen with everyone and in every disease, and the error, the medical error. And this medical error may be simple or a medical error which is severe or gross medical error. This gross medical error, usually no one will fall into this gross medical error because it specialized three things that are considered this gross medical error. The first is to work under while you are drunk or taking some sort of a drug or something like that, or you didn't help someone who has some sort of medical error from you, although you can help him or her. And then the third, if you practiced medicine or practiced anything outside the scope of your clinical privileges and outside the scope of your specialty. This gross medical error is the thing that we all should be aware of and keep ourselves away from this. The medical error, the simple medical error, can be dealt with in many ways. In this medical liability law, I would like also to say that القيام بأي إجراء طبي بالمخالفة للتشريعات المعمول بها أو الدلائل الإرشادية للتدخلات الطبية المعتمدة من المجلس الصحي المصري. Our clinical practice guidelines that are put by the committee and under the umbrella of the Egyptian Health Council, you are responsible to follow all of these guidelines. Unfollowing these guidelines is considered one of the medical errors. So please, everyone, you have to log into the Egyptian Health Council website, download these clinical practice guidelines, memorize them by heart, and practice them and apply the recommendations to your patient after thorough judgment about the condition of your patient. Now let me go to the guideline of the cesarean section. Before I go also to the cesarean section, I would like to tell you a story. This is a true story about Mrs. X. Mrs. X had a birth that changed everything. She is 20 years old, 28 years old, prima gravida, 38 weeks pregnant, and she is having healthy pregnant, and she has a very good general health. A cesarean section was performed, and there was no medical indication for this cesarean section. After 3 years, a second pregnancy occurred, and repeated cesarean section was done. Then everything went wrong. Severe hemorrhage, emergency hysterectomy, bladder injury, massive blood transfusion, disseminated intravascular coagulation. The abdomen was closed, then reopened for hysterectomy, but unfortunately, Mrs. X died. So it all has been started by unindicated cesarean section, which makes every labor after that a problem. In normal labor, every labor paves the way to the next labor. As she goes into more and more labors, the labor becomes easier and easier. Contrary to cesarean section, as the woman goes into multiple cesarean sections, every cesarean section is more difficult than the older one, and the lady is exposed to grave complications during this cesarean section. So don't ever think that you have done the right thing by getting your woman or your lady all right after the cesarean section. The baby is all right. Nothing is wrong after the cesarean section, but there is something wrong that you did or that you inflicted, is that you did a cesarean section without a medical indication, leading or leaving this woman for unknown future, making every labor later on for her a problem. So the first decision of the first birth influences every future pregnancy and impacts maternal morbidity. The question is, who killed Mrs. X? She died in her second delivery. But was the first doctor to be blamed or not? I would like every one of you to think thoroughly about this. And also think how many potential Mrs. X's only by doctors present in this webinar. How many potential Mrs. X's? Mrs. X is a very healthy woman who had normal pregnancy, and she has went into unindicated cesarean section. So she is a potential woman for later on morbidities. So we must ask ourselves how many future Mrs. X's began with a decision made by us. For who killed Mrs. X? Do you think the unnecessary primary cesarean section has a role? And if this role is present, is it the major role or something trivial? The fear of litigation from the doctor. They fear of natural delivery or normal delivery because they fear litigation. But I would like also to mention that the majority of the trials or the lawsuits that we are dealing with are secondary to problems during a cesarean section, not normal birth. Or is it out of financial incentive? Was the real reason behind the death of Mrs. X? Or the loss of operative vaginal delivery skills? Or perhaps it is the poor labor management or the system normalization of cesarean delivery. Our system now, our doctors now are normalizing cesarean delivery. Cesarean delivery is the norm. In the past, we were taught by our professors that episiotomy is the common surgical intervention done on women. But now we can assure, everybody can assure that cesarean section is the commonest surgery done in our country, because we are having around 2,100,000 births every year. So we are having at least 1,800,000 births a year done by cesarean section. So this is the comment, which is a major surgery and full of complications, from the anesthetic complication to the complication of the surgery itself, to the complications of the next surgery or the next labor, etc., etc. But this problem is worldwide. We know now that cesarean section rate is rising all over the world, but unfortunately, we are number one in the whole world in the cesarean section rate. The latest published cesarean section rate was 72% in Egypt, but the unpublished data of 2025 found that the cesarean section rate rose to 88%. Only 12% of women deliver normally or vaginally. And I think that those 12% are the women who has previous 2 or 3 vaginal deliveries, so they go spontaneous delivery without any problem. The maternal mortality risk increases with every repeat cesarean section, while vaginal birth becomes easier and easier with every more deliveries. There is an escalating risk of multiple cesarean. Every one of us is aware about this risk, and whenever we are going to do a 5th cesarean section or a 4th cesarean section for a woman, we feel that we are going to have to meet some risks, some problems during the cesarean section itself. So, as I told you, in Egypt, our critical situation is that the unpublished cesarean section rate is 88%, but the latest published cesarean section rate was 72.2%. And more than 90% of these cesarean sections are done in the private sector. But are there maternal risks of the unnecessary cesarean section? Definitely every one of you know the short-term risks of hemorrhage, of infection, of thromboembolism, of organ injury, of anesthesia complications. We deal in the medical liability committee with many cases of intestinal injury, many cases of bladder injury, many cases of colonic injury due to previous cesarean section, previous adhesions, etc. Long-term maternal consequences, the placenta previa, the placenta creta spectrum, the uterine rupture, the adhesions, the increased maternal and neonatal morbidity and mortality. I would like to tell you that we may have some sort of selfish look about cesarean section. This selfish look is that if I did cesarean section for the woman, I'm going to finish it within 45 minutes and give her her baby fine. She is fine and the baby is fine. She will go home with her baby, and I have nothing to do with the next pregnancy or the after next pregnancy and cesarean section. All what we think of is that we want to finish this pregnancy safely, irrespective of what's going to occur to the mother on the long term. The neonatal consequences without the exposure of labor, respiratory distress is more common, NICU admission is more common, breastfeeding delay and the altered microbiome is more common. And this altered microbiome may lead to some sort of children show increased risk of asthma, of allergies, obesity and type 1 diabetes are increased in the children born by cesarean section. So cesarean section, when indicated, is a must. It is a life-saving procedure and life-saving operation. But the unindicated cesarean section carries a lot of threats, a lot of risks, a lot of problems to the mother and to the neonate and to the future neonates also and the future babies. So these are our recommendations on the clinical interventions for the prevention or the reduction of the primary cesarean section. First, it starts with birth planning. You have to discuss the risks and benefits of cesarean section versus vaginal birth with the woman, and you have to consider her reproductive future plans and to consider the patient concerns also and discuss these concerns with her. After that, you have to assess the presentation, and this assessment usually done after 36 weeks, and document the presentation and guide the delivery planning, discuss with her the route of delivery and the place of delivery. If you have a breech presentation, offer external cephalic version after 36 weeks, but this external cephalic version must be done by experienced obstetrician. If you are having the experience, please go on and do external cephalic version. If you don't have the experience, if you are in a public hospital, please bring someone who is experienced in this to do the external cephalic version, because this will reduce the need for cesarean section. And if you decided to do a cesarean section for a breech presentation, please perform ultrasound immediately before opening the abdomen. Confirm the breech presentation, because many babies change their position and become cephalic on table. When you open, you may find them cephalic instead of breech. If you are suspecting macrosomia, the cutoff limit of macrosomia is either 4.5 kilograms in non-diabetic or 4 kilograms in diabetic mothers. So don't diagnose macrosomia in a baby less than 4.5 kilogram or in a baby less than 4 kilogram if the mother is diabetic. This is to avoid unnecessary cesarean section for the suspected large fetus. Twin pregnancy. Every one of us know that if the first twin is cephalic, so vaginal birth outcomes are comparable to cesarean section and maybe even easier because the relative size of the babies is small. And cesarean section here does not improve the outcome, and you have to counsel the woman to attempt vaginal delivery for a twin if the first is a cephalic presentation. Cephalopelvic disproportion is now a myth. The prediction tools of cephalopelvic disproportion are no more acknowledged in any recommendation of any society or any international entity or in our Egyptian guidelines. Don't rely on clinical pelvimetry. Don't rely on the maternal height, the maternal shoe size, the estimated fetal weight alone to predict cephalopelvic disproportion. As we all know, the best pelvimeter of the pelvis is the fetal head itself. For hepatitis and the mode of delivery, don't perform cesarean section due to hepatitis B infection. The baby will be vaccinated immediately after birth, and hemoglobin and hepatitis B immunoglobulin may be given to prevent transmission from the mother to the baby. Also for hepatitis C, it is not an indication for cesarean section. And according to the Center of Disease Control, hepatitis B vaccine at birth will be given to the child regardless of the maternal status. If the mother is hepatitis B positive, so add hepatitis B immunoglobulin within 12 hours of birth as immunoprophylaxis. So hepatitis B vaccination is a routine vaccination after delivery, and the hepatitis B immunoglobulin is given within 12 hours if the mother have hepatitis B. Maternal body mass index is not an indication of cesarean section. BMI more than 50 alone is not an indication of cesarean section. On the opposite, it will make cesarean section very difficult, and also it will make infection is very high, the infection risk. So the clinical decision must consider the maternal condition and the obstetric factors in obese women, and knowing that women with body mass index more than 50 kilogram per meter square have a 30 to 50% risk of wound complications, 20% risk of NICU admission, and 1 to 2% risk of maternal intensive care unit admission. So the body mass index alone is not an indication for cesarean section. Now we come to the cesarean on maternal request. The majority of our physicians say that the increased cesarean section rate is because women ask for cesarean section. Okay, We don't have a problem with it. We added it to our guidelines, our Egyptian guideline. But you have to explore the reasons. Why does the woman needs to have a cesarean, wants to have a cesarean section? And you have to address her concerns, especially the pain and the pain relief. And you have to explain the risks and the benefits of cesarean section and vaginal delivery. And the most important is to document this discussion. Document everything you said to the mother. And finally, you have to get a signed consent. The cesarean section on maternal request must include written informed consent with documentation of counseling and a clear signed notice that this is a cesarean section without a medical indication. You have to write it very clearly. This is a cesarean section without a medical indication. And I'm repeatedly saying that this is to save yourself. If something abnormal happened, or if a complication happened and the woman went to court to raise a lawsuit against you, you have to put it clearly. This is a cesarean section without a medical indication on maternal request. So she will have all the responsibility for this cesarean section afterwards. For induction of labor, before 41 weeks, do induction of labor based on the medical indication. But at 41 weeks, 40 plus 7, recommended to do induction to reduce the cesarean section risk and to reduce the perinatal morbidity. Don't wait for the 42nd as we were doing in the past. Terminate pregnancy by induction of labor if the obstetric condition allows on the 41st week. I will not go into the latent phase definition and when to change from normal labor to cesarean section. I will leave this to my colleague, Dr. Ahmed Sikotori. He is going to give you the presentation about the normal labor and when to shift from normal labor, vaginal delivery, to cesarean section. So the latent phase and the prolonged latent phase, the partogram monitoring, the normal labor progress, the protracted labor, and the monitoring protocol of auscultation of the fetal heart sounds, and the second stage of labor are left for the presentation about labor or vaginal delivery. I will only mention the operative vaginal delivery because they reduce the cesarean section rate. But mind you, they are safe alternative cesarean section, but require training and experience again and again. If you are having the adequate training and the adequate experience of operative vaginal delivery, please go and do operative vaginal delivery. And before doing the operative vaginal delivery, you have to take the informed consent of the patient for everything. So if you are going to plan for vaginal delivery, everything that might be done in the vaginal delivery should be written in the consent of the informed consent of the patient before starting labor, and should be very clearly written whether she is accepting to have operative vaginal delivery or not. Even episiotomy, she should sign that you may need to do episiotomy. So please, the informed consent is an essential part of the documents, and it must be documented in every case, either cesarean section or vaginal delivery, any procedure. Even if you are going to introduce a loop, IUD, please take the consent of the baby, of the mother, and let her sign it. The last thing I'm going to tell you is the Robson classification, because now the Ministry of Health and Population requires that every hospital will do Robson classification for the labors that are practiced in this hospital, and they will follow and monitor the cesarean section rate according to this Robson classification. So what is the Robson classification and how is it written and used? The Robson classification is a classification for labors, not only cesarean section, for any labor, done by the WHO in 2014. Every woman admitted to delivery in any facility can be classified into one of the 10 groups of the Robson classification. So the Robson classification is for all the women who deliver at a specific setting and not only for the women who deliver by cesarean section. The 10 groups are based on 6 basic obstetric variables. All of the 6 variables should be registered, and they are already registered on the file of the patient. Because the parity, definitely we are going to register the parity, whether the woman is nullipara or multipara. We are going to register whether she is having cesarean section previously or not. We are going to register whether she went in labor spontaneously, or we are doing induction of labor, or this is a pre-labor cesarean section. We are going to register the number of fetuses, singleton or multiple pregnancy, the gestational age, it is written whether preterm or term, and the fetal lie and the presentation, cephalic, breech presentation, or transverse lie. All of these obstetric variables are registered in the file of the patient by default. So by returning back to the file, you can classify her into one of the 10 Robson classifications. Here are the 10 groups, and they are very easy to be classified. If you just wrote the group and then you put one mark in front of this group, this means that one of the patients have delivered in class 1, in class 1, either by cesarean or vaginal delivery. And I'm going to show you how. The first group is nullipara with a singleton pregnancy, cephalic, term, went into spontaneous labor. The second is a nullipara with singleton, cephalic, term, but have induced or cesarean section done pre-labor. The third is multipara, single, cephalic, more than 37 weeks, no previous cesarean section, went into spontaneous labor. The fourth is multipara, single, cephalic, 37 weeks or more, no previous cesarean section, induced labor or cesarean section pre-labor. The fifth group is multipara, single, cephalic, 37 weeks or more with one previous cesarean section or more. So we can find here all the women here, either nullipara or multipara with singleton cephalic term, and either went into spontaneous labor or have induction or cesarean section pre-labor. These are the 5 groups. The 6th group is the breech, nullipara, single, breech. The 7th group is the multipara breech, multipara, single, breech. The 8th group is multiple pregnancy, the twin and the triplet. The 9th group is the transverse or oblique lie. The 10th group is the preterm labor. So if you are having a preterm baby, immediately this is the 10th group. If you are having a transverse or oblique lie, immediately this is in the 9th group. If you are having multiple pregnancy, immediately this is in the 8th group. If you are having breech, multi, 7th group, breech, nullipara, 6th group, and the first 5 groups are classified according nullipara or multipara and spontaneous labor or induced or cesarean section pre-labor. All are singleton, cephalic, full-term pregnancies. You don't need a team of statisticians to do this Robson classification. You can see here, this is the group 1. Parity is 0 because all are nullipara. Previous cesarean section, no. Number of fetuses, 1. The presentation is cephalic. The gestational age is 37 or more. The onset of labor is spontaneous. Put this in an Excel sheet, and whenever you are having a vaginal delivery, add the number here. A cesarean section, add the number here. So this is a complete sheet of Robson classification with the number of cesarean sections in this class, the number of vaginal deliveries in a given period in this class, and the total number of deliveries. This is the Robson classification, very simple classification to classify women who went into labor. And thank you very much. And I'm ready, of course, at the end of the webinar to answer any question. Thank you very much.
Thank you, Professor Abdulhamid, very much for your presentation. And I'm sure that there will be many questions, mainly because you are a member of the Committee of the Medical Liability Law. I believe this will raise many issues for discussion at the end. Thank you for raising the attention of the importance of the Egypt Health Council guidelines, and it is the standard or the base for accountability in the medical liability law. Thank you so much, and we will receive the questions at the end. Our final scientific lecture will focus on one of the cornerstones of preventing unnecessary cesarean section, which is the safe management of normal labor. Of course, as you know, we have many different figures in normal labor in different countries, and so we have to put our own labor care guideline. It's my great pleasure to introduce Professor Ahmed Sekitouri, the consultant gynecological oncologist and minimally invasive access surgery. He honorary professor at the National Cancer Institute in Cairo and a professor of obstetrics and gynecology at the University. Professor Ahmed will discuss the management of normal labor. Please, Professor Sekitouri.
Enjoyed the day. Thanks for the introduction, Professor Wafa. Enjoyed very much the day and Professor Abdelhamid's talk. Very up to the point. I'm going to talk about the normal labor care guidelines. That's the art of normal labor, which is the art of the minimal intervention, the art of active observation and active monitoring, intelligent monitoring with the minimal intervention of labor. The slides are changing.
Yes, Professor Sekitouri. Yes.
Okay, thank you. In Egypt, as Professor Abdelhamid mentioned, we have the highest cesarean section rate. One of the highest is 72% nationally at the moment. And we need to change this attitude of cesarean section and attitude of patronizing ladies delivering and imposing clinical decisions on them by respectful maternity care and physiological trust, and by minimizing the intervention, as I've just mentioned. The normal labor is a labor that occurs between 37 and 42 weeks, has to be spontaneous onset, not induced, has to be a singleton pregnancy, obviously, not a multiple pregnancy, with a cephalic presentation, normal labor progress, and spontaneous vagina ends with a spontaneous vaginal birth, and no maternal or fetal complications or any other identifiable prepartum, intrapartum, or immediate postpartum risk factors or complications. How to admit the lady to the labor ward, or whether to admit her or not. As we know, we have one of the busiest maternity hospitals the world globally. So we do not want to overcrowd the maternity wards with ladies in the latent phase of labor, or even in the pre-labor. So the patient will present with painful contractions. That's her first presentation, particularly if she's a primary gravida in her first labor that doesn't know so much about the experiences of labor. So, in fact, I forgot to change the slides here because I'm presenting from two devices. So the cervical dilatation will be assessed. If she is less than 5 centimeters, she's now in the latent phase of labor. We can observe for 2 hours. And if she is still in the latent phase, she can have the option of going home and coming back. Or she can be admitted if she is about to go into labor with 5 centimeters cervical dilatation or more, or if there is a spontaneous rupture of the membrane. Obviously, there are some unwritten rules here, where if the lady knows she's coming from a far place, she's not resident in this country, in this town, and there is no one to take her back. And we sometimes get faced with this situation. So an early admission to the antenatal ward, not to the labor ward, may be considered in that scenario. The general care rules and fluid management during labor. The lady should be encouraged to have adequate hydration. Normal drinks, isotonic drinks may be better than pure water, and not to overdrink. Intake of too much water with a positive balance of more than 150 milliliter can cause hyponatremia. So we should encourage the lady to be well hydrated, isotonic drinks, lemon juice, for example, but not to overdrink. The routine pubic hair shaving is not recommended. There is no recommendation for an enema before delivery or during the first stage of labor or the latent phase. And the routine administration of IV fluids in ketonuric ladies without diabetes is not also recommended. Maybe you can give IV fluids in ladies appearing clinically dehydrated. She can continue on light diet. She can have the isotonic drinks, as I've just mentioned. She can be freely mobile. The upright position is preferred than the supine position. That allows for better descent of the fetal head and pressure on the cervix, which allow good cervical dilatation. In the first stage of labor, we assess for the latent phase the duration and standard. Historically, latent phase can be long, can go up to 20 hours in the nullipara, 14 hours in the multipara. But really, there isn't a recommendation for a trigger of the duration of the latent phase. So if the lady is in a good shape with general condition, the baby is fine, the intermittent auscultation is okay, then we can allow the latent phase to continue. Obviously, there are limits for that, which is approaching the 20 hours for the nullipara or 15 hours for the multipara. We screen during this phase for any development of complications by taking maternal observations like blood pressure, pulse, respiratory rate, taking the fetal observations for intermittent auscultation, assessing the emotional and physical needs for the lady, if she is dehydrated, if she wants to mobilize, and so on and so forth. She can have nutrition and hydration, as I just mentioned, non-pharmacological pain relief like breathing exercises, warm baths, massage, and all this. Psychological needs can be addressed by allowing the partner in certain permissible conditions. Not all the facilities will allow this, but at least for those who can have the partner or the husband or family member with them during that phase, this will allow for a convenient and straightforward latent phase of labor. The active phase of the first stage of labor starts from 5 centimeters cervical dilatation. Before that is the latent phase. The nullipara or the multipara should progress of not less than 5 millimeters 0.5 centimeters, 5 millimeters per hour, i.e. 2 centimeters in 4 hours. The maximum duration that we allow for the active phase of the first stage of labor is around 12 hours for the nulliparous lady and 10 hours for the multiparous lady. It appears quite long, but this has been tested and assessed and proved to be safe so long as the maternal condition and the fetal condition are normal. Vaginal examination interval every 2 hours, and we should obviously minimize vaginal examination to reduce the infection risk. We shouldn't routinely use amniotomy or oxytocin to prevent delayed progress. Routine vaginal cleansing with chlorhexidine is explicitly not recommended. It doesn't prevent infection in the normal conditions. We usually advise for using the partogram. Usually labor does not accelerate until a threshold of 5 centimeters is reached, which is the active phase. The 1 centimeter per hour is no longer applicable. That's in terms of cervical dilatation. And now it's 0.5 centimeter per hour. So 2 centimeters in 4 hours is acceptable as a minimum of cervical dilatation progress. The fetal monitoring protocol.
Change the slides,
please. Yes.
Yes, that's the slide for the cervical dilatation. The fetal monitoring protocol. The active first stage every 15 to 30 minutes. In the second stage, every 5 minutes. The duration, a minimum of 1 full minute immediately after a contraction or towards the end of a uterine contraction. This is to assess late decelerations. And prolong over to cover 3 contractions if the fetal heart rate is abnormal, is outside the range of 110 to 160 beats per minute. Always palpate the maternal pulse simultaneously to differentiate heartbeats. And that's a rule that we shouldn't really forget. Now, if the maternal heart rate is more than 120 beats per minute on more than 2 occasions, we should escalate to senior obstetrician who may need to consult an anesthetist or a physician. If the blood pressure is more than 160 over 110 in one reading, or twice over 140 over 90, 15 to 30 minutes apart. If the temperature of a single reading is more than 38 or equal 38 degrees, or 37.5 on 2 occasions 1 hour apart. If the respiratory rate as well is slower than 9 or more than 21 breaths per minute on 2 readings 15 to 30 minutes apart. This should be escalated to a specialist or a senior consultant obstetrician and gynecologist. Also, if there is fresh red bleeding, there is new appearance of meconium, if there is a persistent abnormal fetal heart rate pattern, free-floating head or a very high head, more than 4/5 or 5/5 palpable, and in the first or second stage, in the late active first or second stage, or there is incident of abnormal presentation like cold presentation. With protracted labor, i.e. cervical dilatation of less than 2 centimeters in 4 hours, 1 centimeter per hour, less than 0.5 centimeter per hour, we support the woman by good hydration, explanation of what's happening, reassuring her that...
Advance slide, please.
Reassuring her that that most women will generally come out of this slow progress and progress into a normal labor at the end by themselves or by the help of medications like what we'll see later. So explanation and reassurance will help the woman, her family, and will help the doctor to implement the agreed plan. Always explain to the lady and reassure her. Doing amniotomy, if membranes are still intact, we can start oxytocin if the contractions are less than 3 to 4 per 10 minutes. And discontinue the oxytocin if there is any problems with the fetal heart rate outside the range of 110 to 160, or there are late decelerations or the variability is abnormal. And reevaluate every 2 hours. post-regular contractions. So we have to have regular good contractions, 3 to 4 contractions per 10 minutes, and then we assess after 2 hours. If this is happening and we assess after 2 hours and there's less than a 1 centimeter change or less than 2 centimeters after 4 hours of oxytocin and good uterine contractions, then we consider the diagnosis of arrest of labor, failure to progress. A senior obstetrician then can be consulted for the decision of cesarean section that should be safely performed if it is deemed necessary. Analgesia range from the non-pharmacological methods like breathing, water immersion, massage, and that's in the latent phase of labor. There's no usually risk on the mother or the baby on that. Obviously, water immersion in the rupture of membranes or the presence of meconium or maternal comorbidity, we are here outside the limits of normal labor. So I'm not talking about normal labor. We can give opioids, fentanyl or pethidine, with the consultation of the attending anesthetist as well. We provide the antiemetic so that the lady may not have nausea and vomiting. And we should not give it if the delivery of the baby is expected within 3 hours. It may happen that short-term respiratory depression on the baby or drowsiness hindering breastfeeding. We should also alert the attending neonatologist about the received opioids if the lady has had one of them. Epidural analgesia, very important. We call this conditional because it might not be present in all delivery wards or maternity hospitals. The protocol should be co-managed with the anesthetist. The ladies should be catheterized. That's our responsibility for that, with continuous CTG for at least 30 minutes post each bolus dose of the epidural. The lady can have mobile epidural where she can walk in her room with the epidural, obviously with the attending nurse. If we give epidural, we have to wait a little bit in the second stage, delay for pushing by 1 hour for the multipara or up to 2 hours in the nullipara, or until we feel the head is visible or the urge to push is there. There's no routine use of oxytocin in the second stage to accelerate it if we give epidural. So we have to just observe the progress as per normal. If she is progressing normal, there's no need for oxytocin. If there is delay, we can administer oxytocin. Now, for the nulliparous, full dilatation to birth with diagnosis of delay of longer durations than 2 hours or insufficient descent by 1 hour. This is for the nullipara, or in the multipara by more than 1 hour total or insufficient descent in 30 minutes. However, longer durations can be acceptable if maternal or fetal conditions are altered, particularly if epidural has been administered. Fetal monitoring, we increase the fetal heart rate auscultation to every 5 minutes. If we consider operative vaginal delivery, forceps, vacuum, or ventouse extraction should be done by trained physician if it is deemed safe. And if that's the case, that's a very, very acceptable alternative to cesarean section and should lead to reduction in the cesarean section rate. The application of manual fundal pressure is absolutely prohibited, absolutely, and this is a strong recommendation. We are going to do episiotomy. This is a left-handed diagram, but it should be 45 to 60 degrees to the vertical line so that we avoid the external sphincters. And that's not a routine practice. It should only be done to prevent tear or to facilitate instrumental delivery. Recommend hands-on guarding of the perineum, warm compresses, and perineal massage to reduce the 3rd and 4th degree perineal tear. In terms of the 3rd stage of labor, we should practice delayed cord clamping after 1 hour. This will allow more blood to go into the baby from the placenta, unless the baby is, showing signs of distress or asphyxia and require immediate removal from the mother or immediate delivery and handling to the neonatologist. So it is recommended that delayed cord clamping should be practiced in all ladies. In terms of controlled cord traction, it is recommended, and it should be started after signs of placental separation, where the cord is gently pulled down and the uterus by the left hand is gently pushed up after signs of placental separation, and making sure that the uterus is contracted. In terms of uterotonics, the armamentarium that we use is oxytocin, and that's the most widely used drug during labor. We give 10 international unit IV slowly over 3 to 5 minutes, or 10 units intramuscular for ladies who have no IV access. If cesarean section, we give 5 international units very slowly IV. Avoid the rapid bolus administration. Or ergometrium IM is not widely available these days, but we shouldn't be giving it for ladies with essential or pregnancy-induced hypertension, or certainly with preeclampsia. Carpitocin indicated if the storage of oxytocin is not guaranteed, or oxytocin is not available, and it's cost-effective for cesarean section under regional anesthesia. Single dose only should be administered. Or in low resource setting, if these drugs are not available, we can have 600 micrograms of oral or sublingual misoprostol administered after birth. Prophylaxis for the high-risk ladies, or ladies with continuous trickling of blood, can expand to involve administration of tranexamic acid, 1 gram in 10 milliliters IV over 10 minutes. We give it within 3 hours of birth. We should really monitor the lady in the postpartum period. Yes, she has delivered safely and she is fine and the baby is fine, but we just need to complete the 3rd stage of labor in the same safe manner, so that we have the overall outcome of a safe mother and baby, because certain risks can occur or complications can occur after an apparently normal, straightforward vaginal delivery. So every 15 to 30 minutes, we should check the blood pressure, heart rate, respiratory rate, blood loss, check temperature every 30 to 60 minutes, check the contractions of the uterus every 30 minutes, and document all that and consult the attending obstetrician if there is any deviation from the norm. The continuous massaging of the uterus is not recommended if the uterus is already contracted and the lady has had her prophylactic oxytocin. If episiotomy has to be done to prevent perineal tears or to facilitate instrumental delivery, we then should ensure effective tested analgesia. So after giving the analgesia, we should test that the lady is not feeling pain. And we use absorbable synthetic sutures, and these are used these days, like Vicryl,
Hi,
for
Dr.
example.
Ahmed.
Slide? Yes, yes. Sorry. We use continuous non-locked suture for the vaginal wall and muscle, and continuous subcuticular for the skin. Rectal examination should occur or should be performed after the complete suturing of the episiotomy incision, and we can administer rectal non-steroidal analgesia. We should assess the lady for thromboembolism. The discharge window is between 12 to 24 hours post uncomplicated facility birth or uncomplicated vaginal birth. However, earlier than that, discharge can be performed or decided upon mutually with the doctor, the attending doctor. We should encourage breastfeeding, and this is in collaboration with the neonatology team. We advise iron supplementation for those with known anemia, and check baby RH status, obviously, in all deliveries. If it has not been checked antenatally, and stressing on checking this as soon as possible within the first 24-48 hours if the facility has had no no possibility of checking the RH in the hospital in that case. How to monitor and have a quality dashboard, as it were. We have to document the percentage of low risk women admitted with less than 5 centimeters dilatation and find the reason why they were admitted. Were they not resident in this area? Is this a catchment area for people without family members, or most professionals are not living in that area? We should document the percentage of low-risk labor monitored via intermittent auscultation. We should also document the percentage of patients in progress, normal labor receiving routine amniotomy, oxytocin without delay diagnosis, the postpartum hemorrhage prevention. We should also document this and assess the patient experience of the whole labor journey. How many of them were satisfied? How many of them requested analgesia? Where they received the analgesia in a timely manner, or this has been delayed or not available at all. This will allow for a reduction of the current 72% cesarean section rate, and will allow for women to have a more favorable experience with birth. Sorry, thank you very much.
Thank you very much, Professor Ahmed Sektouri, for this very precise and elegant presentation, and the very well visually presented as well. I believe this is a piece that will help everyone in managing labor according to the Egypt Health Council guideline. Now we are moving to our last part of this evening webinar. We have 15 minutes for questions and answers, and actually I've got many questions, so I'll do my best to try to finish them as fast as we can.
Yes, and this presentation is available, Dr. Wafa, for sending to anybody that needs it.
Thank you very much, because it will be very helpful for a lot of people to follow. Thank you. My first question is for Professor Sektouri about the latent phase and prolonged latent phase, especially a non-engaged head for a primary gravida in prolonged latent phase. Is it indication to go for cesarean section, and for how long one can wait for this patient?
We might not expect the head to engage in the latent phase of labor. So we go with the timing. If the baby is fine and the lady is fine, the latent phase can go on for up to 20 hours, So it's not by the head itself, it's by the condition of the mother and baby. if we explain to the mother that she's fine and the baby is fine, and that's normal to have a prolonged latent phase, and if we monitor the lady and make sure that she is fine, the baby is fine, she's well hydrated, she is not in pain, she is not suffering, then we can allow for that to happen, particularly if the membranes are intact, you know.
Yes. So the head engagement, non-engaged head in a prime gravida is not an indication for cesarean section.
Yes.
Because this is the giest category in Egypt for elective cesarean section in the prime gravida.
Yeah.
Thank you so much.
Yes, allow me, Dr. Wafa, also to
Yes,
add
please.
that the classic teaching is that engagement of the head in a prime gravida usually occur in the second stage of labor. So we shouldn't wait or look for engagement before labor and say that the head is high, it's not engaged, so we have to go into cesarean section. We shouldn't wait for in the latent phase and look for the head and say the head is not engaged, we have to go to cesarean section. Even in the first stage, in the active first stage of labor, the head usually is not engaged. Engagement of the head in a prime gravida occurs mostly in the second stage of labor.
Thank you, Professor Abdulhamid. Second question, Professor Abdulhamid, although you clarified, but I have this many times from one from Dr. Nada Sami. She's asking about the maternal cesarean section on maternal request. Is it a sufficient indication for cesarean section from the medical legal point of view? And how to document?
تفضلي دكتور وفاء.
How to document يعني documentation للmaternal request as an indication for cesarean section?
Well, actually, Professor Dr. Nada sent this question before my presentation. So in my presentation, I said that cesarean section on maternal request is allowed after fulfilling the conditions. The condition is to discuss with the woman what are her worries and to try to convince her that these worries are not grounded. And then after discussing with her what are the possible complications of cesarean section and what are the possible complications and benefits of cesarean section and possible complications and benefits of normal labor, then if she insists that she will have a cesarean section, we should document this, that this is a cesarean section on maternal request with no medical indication. The woman should sign this request so that the physician or the doctor is clarifying himself if anything abnormal happened or a complication happened and the women went to file a lawsuit against the physician. Dr. Wafa?
Dr. Abdulhamid, how we apply this to the Robson criteria or categories?
There is no indication in the Robson criteria or category saying that this is cesarean section on request.
We attach a piece of paper because now the Robson criteria paper is clamped or clipped to every case notes. So
yes, and also the partogram should be added to with the Robson criteria of the partogram of the woman, and even if there is a consent like this should be also photocopied and sent with the Robson criteria.
Okay.
Thank you, Professor Abdulhamid. I have a question for Professor Mohammed Murad. It's about the compliance or the compliance with the guidelines. Who is the body responsible for monitoring the compliance of different practitioners with the guidelines? How we can monitor this? What is the plan? Yes.
The plan, as you know, Dr. Wafa, each clinical guideline issued by the Egyptian Health Council contains a section called Clinical Indicators for Monitoring. And it's monitoring not for the patient, it's monitoring for implementation of the clinical guideline. So each guideline has like a checklist, so we can audit any health facility if the guideline is implemented in the facility or not. For example, if we, like preeclampsia, the clinical indicators may be blood pressure measurement, urine analysis, renal and liver function test, coagulation profile, administration of antihypertensives, administration of anticonvulsants, some points in the checklist. So anyone who will go auditing this health facility will pick up all the medical files, for example, in the last 6 months with preeclampsia, and sees if these indicators, how many indicators were fulfilled in each medical file, and then gives a score for the health facility, like the health facility has implemented this guideline by 60%, 70%. So it will be auditing for implementation of these clinical guidelines. Actually, this will work only in the hospitals under the Egyptian Health Authority, like the insurance. All right, التأمين الصحي الشامل, not the previous one, التأمين الصحي القديم. So the governors that have been under this program are actually being audited. But to be honest, they were auditing only quality and infection control, because the auditors are mainly dentists or pharmacists or GPs, and we cannot afford to send an obstetrician to audit the medical files in the obstetrics department and so on. So we are creating checklists in the guidelines for these auditors, so that when they go to the hospitals, it's easy for them to audit the implementation of the guideline. Of course, this will take some time. It's a long road. We are only at the start of the program, but this is the program in the future, and already GAHAR are cooperating with the Egyptian Health Council, and all these checklists will be with them to monitor the implementation of the guidelines, but only in the hospitals, in the governors that have التأمين الصحي الشامل, and not the previous التأمين الصحي القديم.
Thank you, Dr. Murad. I have a question from Dr. Tariq Sayed. What's your opinion of implementation of recent WHO labor care guide versus the old modified WHO partogram? And do you think it will make a difference in terms of reduced cesarean delivery? Maybe Professor Hamid or Professor Turio. Yes, please.
Well, actually, we had a very heated conversation about the use of the labor care guide versus the partogram. And then our opinion was to continue with the partogram. This is because in the undergraduate, we teach students about the partogram. In the mastership, we teach students or mastership candidates about the partogram. In the fellowship, we teach the fellows about the partogram. We didn't incorporate the labor care guide in any of our either undergraduate or postgraduate teaching. So actually, those who know about the labor care guide are very minimal sector of the obstetricians. So we started with the partogram, which is well known by everyone, and then after we asked the universities, we asked the fellowship to introduce the labor care guide in their curricula. When we are having a critical mass who know about the labor care guide, we may shift and change the guideline into the labor care guide. But currently, we are restricting ourselves to the partogram.
Thank you, Professor Hamid. I have many questions about the lack of facilities in different hospitals, especially outside Cairo. Many of them lack of anesthesia, lack of CTG. What is the situation and the medical liability law in these situations? If they rush into cesarean section because they are fear of fetal monitoring, intermittent auscultation sometimes is not enough. There is no patient anesthesia. What's your views about all these circumstances?
Well, there is also a misconception that CTG or electronic fetal monitoring should be present for every case of vaginal delivery. This is not the case. No international even guidelines do not agree for electronic fetal monitoring for low-risk pregnancies or low-risk deliveries. All the guidelines say that using electronic fetal monitoring in low-risk pregnancy just increase the cesarean section rate without any benefit to the fetus. So we restrict to the electronic fetal monitoring to high-risk pregnancy, a woman with preeclampsia, a woman who is having some sort of antepartum hemorrhage or whatever high-risk pregnancy. For low-risk pregnancy, intermittent auscultation with the doptone, sonicate, or even the Pinard stethoscope. I have been flamed by some of my colleagues about using the Pinard in 2026. Then I showed them the guidelines of the Wales, the guidelines of New Zealand, the guidelines of many international guidelines advocate for the Pinard or the doptone in the fetal monitoring. In the first stage, active first stage, every 15 to 30 minutes. In the second stage, every 5 minutes. So this is a misconception that electronic fetal monitor should be present. This is number one. The second is the anesthesia. I don't know, I cannot write in a guideline that every woman should be delivered by cesarean section because some hospitals has no anesthetist available 24 hours.
Yeah.
This is not a guideline. And we have to put the guideline. The best practice is that cesarean section should be done in these indications. If these indications are not present, so the woman should be allowed vaginal delivery. For myself, I have either one of two choices. If I am not having an anesthetist, please transfer the woman to another hospital where she can deliver vaginally. Okay, but saying that I don't want to deliver her vaginally because I have an anesthetist, I don't find a ground for this. The second thing to do is that you have to ask the hospital manager and the administration to have anesthetist available 24 hours a day. And then the last thing that I would like to say, I am not representing the Ministry of Health and Population to defend the Ministry of Health and Population or to present it. I am representing the guideline working group. We should restrict ourselves to the international guidelines and to adapt it to our circumstances. And our main aim in the guideline is patient safety. This is the main aim of the guideline, patient safety.
Yeah.
And our physicians should adapt themselves to our system, and everyone should know what to do if there is a case of vaginal delivery and he has no anesthetist. I cannot understand how comes that I can have an anesthetist to do a cesarean section. I have a woman coming in labor, and now the time is 2 a.m. in the morning. So I can call an anesthetist to come to do a cesarean section. But if she went into the second stage or she had a complication, I cannot call the anesthetist to come to have a cesarean section. I am somewhat يعني مش
I
قادر
think Dr.
أفهم.
Hamid, يعني Dr. as Dr. Murad said, the monitoring criteria or the auditing parameters for the maternity care will allow the usage of the guidelines as a leverage to complement or complete the staffing level required for safe maternity or safe labor and delivery and reducing the cesarean section. In the United Kingdom, about 90% of the maternity units have 24 hours epidural service. So there are 10% still not having epidural 24 hours. The rate of usage of epidural in the United Kingdom is about 60%, or up to 60%. So it's not, just above 50% of the ladies labor with epidural analgesia. So we have put the guidelines, as you rightly mentioned, and for those responsible for staffing the units and equipping, providing the maternity units with the necessary equipment to allow these guidelines to be implemented, those should take these guidelines and find out how they can provide a full comprehensive service according to it.
Okay.
Thank you, Professor Secretary. Thank you, Professor Hamid. This answers part of the question of Dr. Afrah Hassan, who was from Somalia, and she was a resident in Cairo recently. She was asking about the hospital policies. I believe this that you talked about is about the hospital policies, and she's also asking about the patient education to reduce the cesarean section rate. And I'd like to say to her that today we talked about the clinical interventions to reduce primary cesarean section. However, there is another guideline on the website of the Egypt Health Council about non-clinical interventions, about patient education and support during labor and other stuff. And I encourage everyone to have a look on the website mentioned by Professor Murad and see the other guidelines by the Egypt Health Council. Dr. Asma Aid is asking about inquiring about having the presentation on the WhatsApp group. We will do our best to vote in the group by permission from our professors. And the last question that will end with it.
Dr. Wafa,
yes.
Please ask the doctors to have the guideline itself, not the presentation.
Yes, please,
They
of
will
course.
benefit
Yes.
from the
Yeah,
guideline,
I
not from the
encourage them
presentation,
to go into the website. I've
Yes.
just said, yes, please go to the website. You can see and download
We can provide the link as well.
Yes, we can put the link in and share the link with other with your colleagues in order to be aware of the Egypt Health Council guidelines. I believe how many now, Professor Abhamid, on the website?
In them?
How
many?
many
We are having
guidelines?
Nine guidelines.
Nine finished already guidelines. They are present,
Yes.
and very soon will be more. Encourage you all to go and have a look into that. Maybe two questions. One from Dr. Iman Bastawisi. She's worried about the 3rd and 4th degree perineal tears and the medical legal responsibility of the doctor, because of course we have a famous story in Egypt about the penalty that a doctor had when a patient went into 4th degree perineal tear during vaginal delivery. Dr. Abhamid.
Yes. Well, yeah, fear of complications is present in every procedure. And if you are going to do cesarean section, complications, you may injure the bladder, you may injure the ureter, you may do any complication, and the woman may file a lawsuit against the physician. If you are doing, how many women went into 4th degree perineal tear? And how many women went into bladder injury, into ureteric injury, into even extension of the uterine incision, then went after that into ruptured uterus. So fear of litigation and fear of complications will make us, when we will not work, we will not practice obstetrics. If you are going to do episiotomy properly and in the proper direction and in the exact time episiotomy is needed, 4th degree perineal tear is very, very, very unlikely. And if we are having some sort of a complication or a lawsuit as a committee, and we are looking at it, if this is a complication that is written in the literature, we usually write this. This is a complication that may complicate vaginal delivery, and it occurs in the literature around, say, 6 per 1,000. So it has an incidence, and it can happen with any physician. So please, consider this a complication. It is not a medical error. Okay, so don't fear of litigation if this is a complication that is present in all the references and in the literature. Don't fear of complications. The most important thing is to know how to deal with complications, how to correct this complication. This is the most important thing. But if you did a complication, you didn't discover it, you didn't repair it well, and it led to more and more complications to the woman, this is the problem. But if you are doing cesarean section and you are having tear in the bladder, and then you didn't recognize this tear and you didn't suture it properly. We are having many cases like this, and then the woman developed peritonitis later on, reopened once again. We're having cases of colostomy due to colonic injury. We are having cases of intestinal resection anastomosis due to intestinal injury. So complications can occur with anything. We are even having lawsuit in an intrauterine device, because the doctor, while introducing the device, she just penetrated the uterus. She did a perforation and she didn't recognize the perforation, and the woman had to remove this IUD by laparoscopy with another physician who took a lot of money. So she filed a lawsuit against the woman, against the physician. And when we looked, this is a complication that can occur with anyone who is introducing IUD. So please don't fear of complication. Fear only that you do not recognize the complication and that you do not correct this complication properly. Okay?
Thank you. Thank you so much, Professor Hamid. And I believe this answered Professor Khulud El-Salami question about the medical, legal, and the social blaming after complication. I believe the answer was very sufficient. I just, if you allow me, I would like to add on the third and fourth degree perineal tear that the art of normal labor has been lost from our junior doctors in Egypt, and also the repair of perineal tears. And as ERC-RCOG, we are leading the training on an animal lab for OASIS, or obstetric anal sphincter injury repair. And we are doing this workshop or course regularly. And I believe it should be mandatory for every obstetrician practicing normal labor to go into one of these courses, just to have the knowledge about the standard of repairing third and fourth degree perineal tears. As we come to the end of today's webinar, I would like to express my sincere gratitude to
قبل ما
all
نقفل بس
our yes.
نص
اتفضل يا
دقيقة
دكتور حميد. طبعا اتفضل
وهتكلم
يا فندم.
بالعربي. أنا عايز
اتفضل يا
أبعت
فندم.
رسالة طمأنة لزملائنا أطباء أمراض النساء والولادة. يا جماعة القانون حدد لنا، أنا عشان كده في الأول وريتكم قانون المسؤولية الطبية. إحنا لما بنتعامل بيبقى مطلوب مننا نحط علامة صح في خانة من الثلاثة. هل دي كومبليكيشن واردة، ولا ميديكال ايرور بسيط، ولا خطأ جسيم؟ خطأ الجسيم أنا قلت لكم على الثلاث حالات بتوعه: اللي بيشتغل وهو سكران او واخد مخدر، او بيمتنع عن ان هو يؤدي خدمة طبية للمريضة بعد ما عمل غلطة فيها، او نمرة 3 اللي هو بيشتغل في حاجة خارج اطار تخصصه. والثلاثة دول ما حدش مننا هيقع فيهم ان شاء الله. يتبقى لنا حاجتين: الكومبليكيشن الواردة او خطأ بسيط. الكومبليكيشن الواردة لا عقوبة عليها، خلاص دي كومبليكيشن وارده. واحنا بنلاقي الفورس ديجري برينيال تير، البريفوريشن اوف ذا يوترس في اللوب، في اثناء سيزيريان سيكشن بلادر اتعورت، اي حاجه بتحصل دي كومبليكيشن وارده، وبيطلب مننا ان احنا نكتب الانسيدنس بتاعها ونحط الريفرنس اللي هو بيدل على هذا، وبنبعته للنيابه مع الاوراق بتاعت المريضه. الحته اللي هي بقى في النص ديت اللي هي الخطا البسيط. الخطا البسيط ده هو مع القانون الجديد بيستلزم تعويض، والدولة عملت حاجة اسمها صندوق التعويضات. في صندوق المفروض الأطباء كلهم بيشتركوا فيه، هذا الصندوق بيتولى دفع التعويض عن الطبيب لو المحكمة حكمت بتعويض. فالموضوع ما بقاش يخوف ويرعب زي ما كان قبل كده، وعقوبة الحبس دي اتلغت، ما بقتش موجودة غير في الخطأ الجسيم. فاللي اشتغل بقى وهو سكران ولا واخد مخدر يستحمل، يعني مش هنعمل له ايه. فأنا عايز أطمن حضراتكم: اشتغلوا بما يرضي الله، اتبعوا الجايد لاينز. لو حصلت كومبليكيشن واردة تحصل مع اي حد فينا من اكبرنا لاصغرنا، مفيش اي مشكلة، لان القانون قال يا اخوانا يا بتوع اللجنة الثلاثية قولوا لنا هل دي كومبليكيشن واردة وبتحصل بنسبة كام، ولا ده هو خطأ من الطبيب. فالموضوع والله ثلاثة ما بقى يخوف زي ما كان زمان. هذا القانون حمى الأطباء من مشاكل اللي كانت بتحصل قبل كده. بلاش نسمع دلوقتي إن هم قابضين على دكتور محطوط حبس احتياطي والكلام ده كله. الموضوع كله بقى في إيد لجنة ثلاثية من ثلاثة أطباء كبار، وهي اللجنة مش اللجنة اللي أنا ماسكها لوحدي يعني، لا ده في لجان كتير يعني. دكتور مراد موجود برضه في لجنة، في لجان في القصر العيني وعين شمس وفي كل الجامعات الإقليمية. فالموضوع بقى مقنن، وبقى يبعث رسالة طمأنينة للأطباء: اشتغلوا صح وما تخافوش. لكن اللي هيشتغل خطأ هو ده اللي معرض نفسه للمساءلة. وبشكر حضراتكم.
شكرا جزيلا دكتور عبد الحميد. يعني احلى حاجه رساله الطمانينه دي اللي حضرتك وصلتها لكل الزملاء اللي حاضرين معانا، اننا ننهي بيها الويبينار بتاعنا. يعني جزيل الشكر لحضرتك ولوقتك ولرئاسه الجايد لاين ديفلوبمنت جروب. شكرا لكل الضيوف الكرام، دكتور بروفيسور محمد مراد، بروفيسور احمد سكتوري، للمحاضرات وللوقت والمجهود، ولكل المجهود اللي بيتعمل في الجايد لاين ديفلوبمنت جروب اننا نطلع بالجايد لاينز لمصر. بشكر الاي ار سي على استضافه الاديوكيشنال ايفنينج ده. بشكر طبعا الممثل في دكتور ياسر ابو طالب، وكل البورد ممبرز الاعضاء الزملاء الاعزاء. بشكر الاستاف بتاعنا من الاي ار سي، مدام جيهان الفقي، مدام رنا، ومدام هبه، وكل الموجودين في المكتب. وبشكر ذا ماركتنج هاوس اللي بيقوموا بتنظيم الويبينار، دكتورة مريم كانت معانا النهارده. شكرا للجميع. انا اسفه اذا كان في اسئله ما لحقناش اننا نجاوب عليها النهارده، لكن يعني اكيد هيبقى في فرص تانية، وممكن تبعتوها لنا، وبرضه نسال الاساتذه اللي كانوا موجودين معانا ونرد بيه على حضراتكم ان شاء الله. والف شكر للجميع، وتصبحوا على خير. wonderful evening ان شاء الله. مع الف سلامه.
شكرا.
Thank you very
مع
much.
السلامة.
مع السلامة.